Hello, viewers. Let us understand today about tension pneumothorax, one of the important surgical emergencies. Let's try to understand what happens, the pathophysiology behind development of tension pneumothorax. As shown in this slide, there is a creation of one-way valve due to the breach in the parietal pleura. Now, this breach in the parietal pleura can occur due to a blunt injury, where maybe a fractured rib, an end of a fractured rib can go and tear the pleura, or more commonly, it can occur in a penetrating thoracic injury, like a bullet injury or a sharp object, which can pierce through the anterior chest wall, leading to the tear in the parietal pleura and creation of a one-way valve. Now, what happens here is, as the patient breathes in, with each inspiration, the air would enter into the pleural cavity as it has got a negative intrathoracic pressure. So, with each breath, the air enters into the pleural cavity, and during expiration, this one way valve closes. So, the air cannot escape out with expiration, leading to trapping of air within the pleural cavity. And this, in effect, leads to a vicious cycle where, with each breath, the air gets enters into the pleural cavity, gets trapped, and cannot escape out during expiration, leading to significant increase in intrathoracic pressure. And because of this intrathoracic pressure, the lung gets compressed and gets collapsed eventually. This also leads to shifting of the mediastinum to the opposite side, as shown here. And because of the shift, the opposite lung also gets compromised. And because of this mediastinal shift, it also leads the vascular compromise. The venous return to the heart is compromised, leading ultimately to cardiorespiratory failure. Now, what are the symptoms and signs of tension pneumothorax, which should be diagnosed clinically before doing any X-ray, as clinical diagnosis is very important here. Now, the patient would be apprehensive, agitated, restless. There would be increasing cyanosis, and patient classically shows air hunger, where the ventilation is severely impaired. There would be distended neck veins. Possibly there may be a subcutaneous emphysema. Patient may have cold, clammy skin going into an obstructive shock. And if you auscultate the chest and percuss the chest, you would find a hyperresonant percussion node, and breath sounds would be absent. So, classical triad of a tension pneumothorax would be an increasingly dyspnea and tachypnea, distended neck veins, hyper resonant percussion note, and absent breath sounds. These are the three classical triad of tension pneumothorax against a background of trauma, intrathoracic trauma, which may be a blunt trauma or more commonly a penetrating trauma. Now, this is a X-ray of a patient with a tension pneumothorax. Here you can see the arrows indicating the collapsed lung, as well as the air which is filling up the entire pleural cavity. This also, the yellow line also shows the flattening of the hemidiaphragm on the affected side. And you can see very clearly this arrow which shows the shifting of the mediastinum to the opposite side. And the right border of the heart, as shown on the red line, is also appears to be displaced towards the right side. So this classical picture of tension pneumothorax is what is seen here. Now, what is the treatment? Immediate treatment is decompression, immediate urgent decompression, which can be done with an angiocatheter or a thick needle of size 14 to 16. Classical insertion site for this needle is second intercostal space in the mid-clavicular line. But it has been found that many a times, because of the presence of great vessels there, as well as the very likely chances of a failed thoracocentesis, this needle thoracocentesis, it has been seen that if you insert the needle in the just anterior to the mid-axillary line on the fifth intercostal space, the results are much better, and there is an 80% accuracy of entering correctly into the intrathoracic space, leading to effective decompression of the pleural cavity. Now, this needle thoracocentesis should be followed by intercostal chest tube drainage for definitive management, and patient should be shifted to the nearest center if this thing has been done at the site of accident. Thank you so much. I would keep coming up with such surgical emergency short videos which would help you in understanding some important surgical emergencies. Please subscribe and like to my video, so it would help me, it would motivate me to make further videos for you. Thank you so much.